I'm Steve DeMello, Director of Healthcare here at Citrus. Welcome to today's Research Exchange. Also like to welcome our online viewers. A couple of reminders. The I for Energy talk this week, which is Friday at noon here in the same auditorium, is the role of supply following leads in highly renewable electricity grids. Final reminder, Cal Day is on April 20th. Campus will be open with a number of activities going on, including a number here at Citrus. If you'd like to know more about it, go to www.calday.berkeley.edu. Most, if not all of us, are familiar with Kaiser Permanente as a leading national healthcare system. What's less known but equally impressive is their research capabilities in clinical care, information systems, innovation, and integration. And I'm really pleased to have Dr. Carol Cain here with us today, who's one of the leaders of that national effort. Dr. Cain is the Director for Clinical Integration at the Kaiser Permanente at the Permanente Federation and part of the Kaiser Permanente Care Management Institute. Prior to joining Kaiser, she was Senior Manager of the Health IT portfolio at the Agency for Healthcare Research and Quality, known as AHRQ. Dr. Cain holds PhD from Stanford University School of Medicine. Please join me in welcoming Dr. Carol Cain.
Thank you, Steve. I'm delighted to be invited here. And I've been told that it's logistically easier if I take questions at the end, but if you have a burning question, there are mics, and so I would be very happy to stop in the middle and answer a question, and I'll leave 10 minutes at the end for other questions. So thank you for having me. I'm at the Kaiser Permanente Care Management Institute. Kaiser Permanente is the oldest group model health maintenance organization. We serve 9 million people in 8 regions across the U.S. We actually do have sort of hardcore departments of research that get federal grants, and I'm sort of in this translational space where we try to take a lot of the results of the research that we do both at Kaiser Permanente and also elsewhere and translate it into practice. So today, my talk will be really about that translation, about what the role is of a healthcare delivery system in creating health and in helping people maintain health. And I'll really be challenging you to think about the kinds of needs that you have in healthcare, and then how a healthcare delivery system might answer them. And what you'll see sort of in the middle of the talk is that we make some attempt at answering sort of a subset of the needs, but I hope you'll agree with me about some of the needs, health needs that you have, and a lot of the opportunity that a healthcare delivery system might have in helping to answer them. Kaiser Permanente, we are fortunate to have a capitated payment model, and what that means is that it places as much emphasis on keeping people healthy as on caring for members when they are ill. And we refer to our patients as members because we really want to emphasize the idea that we care for them even if they aren't ill, even if they're not being designated as a patient at the moment. As Steve mentioned, I'm at the Care Management Institute. Our tagline is making the right thing the easiest thing to do. And we are a organization that sits between the health insurance plan and the medical group to do continuous improvement and really be at that translational edge. So we work at that intersection between research and also the folks in operations in our medical centers who are trying different things. We have about 120 professionals. We, again, look at the research, and then we lead development and tend and feed the clinical library for Kaiser Permanente. So I'm going to organize our talk today around 3 questions. The first question, I think, is where we start in the Care Management Institute whenever we do any of our projects, is with the member, with the patient. What do you, as consumers, as patients, as members, want to do with your health? And then the second question, which is really very difficult, how do healthcare organizations respond? And I'll give examples from Kaiser. And how should healthcare organizations respond? And that I would really throw out to you and challenge you as you listen to what I describe our healthcare organization doing, thinking about, is that the right thing we should be doing, and are there other things we should be doing? And then toward the end, given the healthcare system in the U.S., what are the opportunities? So let's spend a little bit of time thinking about what do you want to do with your health. And I'll divide this up into two sections. If you're healthy, what do you want to do with your health? Well, mostly, I certainly know when I was in college, I mostly just didn't think about it, which is a very legitimate way of approaching your health. But if you are conscientious and thinking about it, you want to track your health. You want to be able to act healthy. Sometimes if you feel like you're getting sick, you want to be able to find a doctor. And then the last is something that we actually work a lot on. Feel like there's a safety net, that someone's looking out for you, that you're not missing any of your tests. It's sort of like when you have your car, you kind of want to take it back to the dealer periodically just to make sure you're taking care of the car okay. You sort of want to feel like there's some system where I'm going to stay healthy and I'm not missing anything. And then if you're not healthy, you want to understand your options, get the right care, keep your doctor in the loop, keep your family in the loop, connect with your friends and peers, and especially in America, pay your bills. So if you're healthy, tracking your health, there's been, and at Citrus you probably know this much better than I do, so this is old research, an explosion of applications in the healthcare market. It's frankly intimidating to those of us who are working in healthcare operations. 19,000 apps targeted toward healthcare in April of 2012. What are these apps doing, and how are we supposed to be responding to them as a healthcare delivery system? And they're using different methods. The largest portion of them are giving information. Some of them are giving measurement and decision support. A smaller subset of them are doing tracking. And a really small subset of them are doing planning and goal setting, which I think is a really crucial part of the activity, especially if you're healthy, of participating and really engaging with an app. And then there are lots and lots of different topics. I think one of the things that we've noticed as we track that market is that that upper left-hand corner in illness and disease management is probably not as fully addressed as these other spaces. And so in our perception, at least, is that the majority of apps are targeted toward being healthy, stress and relaxation, reference and first aid, targeted toward healthy people. So we do feel like there's a big opportunity for applications that support illness and disease management. And here's just a sampling of some of the apps out there. This particular list are the ones that were interesting to us at Kaiser. And there's a lot around medications and being reminded of our pills. And one of the things that we really, when we have our methodology where we start with the needs of our members, is that when we looked at whether or not people were taking medications, we found that probably it wasn't because they forgot, but yet the vast majority of medication apps out there are reminder applications. And so we are finding a little bit of a mismatch between the needs of our members and the kinds of applications that are being developed. And why people don't take medications is a fairly complex question. It has a lot to do with psychology, a little bit to do with fitting in socially, with your perception of yourself as a healthy person, not a sick person. So, as we're looking at the app landscape, we're thinking, there's a lot of really useful stuff out there. And then some of it seems to be aimed at a small minority of the problem, medication reminders as an example, versus the bigger issues. And then there are a lot of really fun apps around that our clinicians can use to get, for example, data, monitoring data on their iPhones and things like that. And then if you're healthy, there's also a whole host of fitness sensors out there for you. There are a couple of emergency response systems for folks who are elderly and at risk but not ill. And then I'm showing you, this is a list I grabbed from the Rock Health website. Rock Health is a startup incubator that Kaiser Permanente is partners with. And I really like this list because of the way that they've put all these different categories of why you would want to create a healthcare app. You might want to quantify yourself. You might want to create the new electronic medical record. And I throw this list up there because I want to encourage those of you who are innovators in this space, first of all, to look at Rock Health because it's a really fabulous organization, and then to approach the healthcare landscape with these questions. What am I trying to do, and then what are some of the people who are trying to accomplish those things? So that's if you're healthy. If you're not healthy, you kind of want to understand your options and get the right care and keep everyone in the loop. So, understanding your options, at Kaiser Permanente, we have, for all of our members, a website, www.kp.org. And here's a little bit of what we have right now. You're able to email your doctor. You're able to see your test results, schedule appointments, refill prescriptions. You are able to select your personal physician, and we put up profiles of all the physicians so that you understand where they train and what their specialties are, and also what their personalities might be, because so much of what makes for good treatment is a good doctor-patient relationship. And then we have My Health Manager, or rather, we have different tools in My Health Manager. We have a total health assessment, and if you take it, you can get a customized action plan from it. And then we have a health encyclopedia and other resources. And I'm showing you one of those resources here. It's a series of tools we have around shared decision making, where we are trying to make sure that, especially for conditions that are preference sensitive, so it really makes a difference what the value system is of the patients and members, that we have tools to support both self-education and then the conversation between the physician and the patient around what the right thing to do is. So in this particular one, prostate cancer is a really good candidate for shared decision making. We've put up a tool where we say, get the facts, look at the different options, and then assess your value system. How do you feel about it? I would rather have surgery. I'm more concerned about the risk of radiation than I am about the risk from surgery. And then we help you make your decision through the tool, review that decision, that's number 5, and then have a summary that you can, in this particular case, print out and bring to your visit and talk to your physicians. And we also have different tools where we have videos, for example, of patients who have experienced different outcomes after something like a surgery and discussing whether or not they regret or really feel good about the outcomes, and especially what we find that's valuable about those videos is the experiences they talk about in terms of activities of daily living rather than just something that pertains specifically to that clinical problem. So shared decision-making is really important to us at Kaiser Permanente, but I would also say that it's an area where we probably lack as many tools as we could have. This sort of thing is fairly basic. The videos are really powerful, but also a little bit labor-intensive. And I think that we really could use innovation and assistance in figuring out how it is that patients and the medical system come to make a decision together about the best course of treatment. When you're not healthy, the other thing that you probably want is to really be in touch with other people who feel like they have, who are going through the same experience. And we at Kaiser Permanente have looked at online communities and recommend a few. And we had, in the 90s, and the early 2000s, experimented with running discussion forums ourselves inside our internal website, and we discovered at that time that the discussions were not robust enough. Our membership wasn't big enough to carry on a really rich discussion online. And so we had our physicians and some of our nurses and care managers participating in those forums. But we eventually decided that wasn't the way to go. So we're now saying, these are some of the other communities that you can engage with. And then we participate in those communities. But we are definitely in the process of figuring out our participation in online communities. And I'll show you a little bit later what we're doing in terms of social media. And then I think, lastly, there's a lot, especially if you're feeling ill, around motivation and sort of doing that marathon, getting through that illness, taking the long haul. And I think there's actually a lot of opportunities there for self-management, self-care, using the support groups that are out there. So this is it's a screenshot from Super Better. It's a particular kind of gaming platform where you set different goals for yourself. So you're sort of on a quest to get better, and then you log, you interact with the platform to to keep track of how well you're doing, all the little steps that progress you toward completion of a quest or completion of a milestone. There's a lot of social support in terms of celebrating successes along the way, and then there's a built-in online community to encourage. And so we really think that this is an important part of the process of getting better, and we are trying to think through how it is that we either recommend tools like this to our members, or whether or not there's a role for our providers, our care team, to participate in such a thing. Is it the sort of thing where the physician team in our medical home would be one of the people on the online community cheering the patient along, and whether it is that we would want to get any sort of data from one of these gaming platforms. And it's a really difficult question, especially when you overlay a metaphor of a game on top of it, because then it's really unclear what kind of data we would want to get from such a platform. But on the other hand, the process of recovery is very much psychosocial, and it's really important for us to understand how people are doing, both clinically, which we by and large understand okay, but also how they're doing in terms of their motivation and their behavioral health. A couple of other things that you might want if you get ill. You might want to be able to take your health record with you. And I would say that this is a mixed bag in American healthcare, that there have been a couple of attempts, very much alive, to try and get your record to go from one organization to another. There are a bunch of formats out there, and we participate, many organizations participate in different health information exchanges. But the amount of information that's being transferred is actually pretty light, pretty slim. And especially if you have complex disease, it's really quite difficult to take. You used to be able to go in and sort of Xerox, however painful it was, Xerox your entire paper record and take it over to your next medical office. But now that so many of our records are actually in an electronic format and stored in databases, it's not actually that clear anymore what it means to take a copy of your entire record and move it from one organization to another. So a lot of efforts going on in this realm. And then this one actually, this is a paper that was recently published in the Annals of Internal Medicine, and you wouldn't think it needed original research, especially in the year 2012, which is when I think this was published. But the idea is that patients would get to read the notes that the physicians had written about their health. And not the patient-friendly version, which we do routinely, but the actual notes. This particular study showed 14,000 patients visit notes and gave them the ability to look at their notes. And then about 5,000 patients opened at least one note. And very, very few reported that the notes caused confusion, worry, or offense. And that is sort of one of the biggest concerns from a healthcare provider perspective, is if we show you what the physician wrote, then all sorts of problems, will occur. Other things that were important from a healthcare delivery system perspective was that the volume of electronic messages from patients did not change. So there was a fear that if patients read the notes, they'd get confused, they'd shoot off an email, and there'd just be a lot of sort of churn and noise in the system. And then the other piece, the result that I pulled out that was interesting to me is that more than half of the patients believe that they should be able to add comments to a doctor's note. And that sounds really reasonable. If you read a physician's note and you think, he missed something or he misinterpreted something, let me add a comment. So it's original research because this is definitely not common practice, but it's something that we anticipate being able to do, just creating more and more transparency in that physician-patient relationship. All right, so I talked a bit about what you might want to do with your health. Let me pause a second here and see if I missed anything, if there was a big bucket of something. Have you been thinking about what you might want to do with your health?
You talked about gaming, and after all, is the patient... Thank you. You talked about gaming, and after all, it's about the patient behavior, right? So if the patient doesn't changes, there's no effect of gaming, right? So do you see any interaction that the gaming has improved patient interaction in terms of taking more medicine, or those kinds of evidence? If you could comment, please. Thank you.
I don't know. I don't have hard evidence at my fingertips, and I would say that where we start with a lot of our models of behavior change is, are you ready to change, right? So when we do an assessment in that relationship, we say, are you ready to change? And if you're not ready to change, there's no reason to recommend any of the tools for change. So given that the patient is ready to change and goes and logs into one of these platforms, I do think that we have seen progress. What we haven't seen is stickiness. So we don't know. It's quite obvious when somebody tries something once or twice and it falls off after, 2 weeks. We're usually seeing a great deal of improvement in that 3-month time frame. So we actually find that, so not on the gaming, but in our other, our group classes, we find that people who complete 6 classes, so not very many, are often much better off than people who just completed 1 or 2, and definitely better off than people who completed none. But I think for a lot of the behavior change, it's really long-term, right? We're talking diet, we're talking activities, and I don't know of data out there that talks about whether people are able to stick with these in the super long term. I would say that the closest research we probably have, I'm not familiar with it, is in obesity and the ability for people to stick with particular diets over years and years. So.
You showed us a bunch of web pages and services that Kaiser offers. How do you assess how well they're working and how much investment to put in them?
I would say that the tools we use are probably the tools that are in the industry. We look at which pages are getting hit. Our departments of research will do targeted studies where they'll have, for example, we had a particular depression application, and we enrolled patients into one arm or another. But I would say that for our day-to-day operations, we're relying on, whether or not a page got visited and how many times and that sort of thing. Good question. All right. Oh, one more?
Well, I think the idea of patients being able to read their doctor's comments is a wonderful idea from the patient's point of view. I just wonder what has been the doctor's reaction. I mean, having people looking over their shoulders, would they be less honest? In certain fields, it may be easier than in other fields, like, say, psychiatry.
Yeah.
I'm not sure you want the patients reading those records. So what kind of direction are you taking to get the doctors on board?
It's a really legitimate concern, and we actually have started. That conversation started when we went from paper records to electronic medical records, right? Because suddenly that was a new level of transparency, even between physicians, right? Because it used to be that you would write stuff in your paper record, and the likelihood of somebody else reading it was relatively low. Suddenly, you put it in the electronic medical record, and not just other doctors are reading it, but your medical assistants are reading it. Your, whatever EMT transport people get to read it. So definitely there was resistance there. A lot of sort of change management and preparation. And I would say that in the transition to electronic medical records, not much about the language has changed. The transition to letting patients see it is a much bigger transition. And I would say we are, as a healthcare organization, moving toward greater transparency. So that's the culture change of saying, shared decision making, nothing about my body without my consent. So really, there is a culture change in terms of how we need to talk about patients, and there's some work there. And I would say that there are certainly areas where we do think that notes should be protected, but they probably aren't as widespread as we currently think. So I would really encourage pushing the envelope there. Because we used to be afraid, for example, when we started putting up our lab test results on kp.org, as soon as they were available, our physicians would say, no, they need those labs explained to them. You can't just put it up. You have to let me review them and have a conversation with them first before they get to see the lab results. And we kind of just turned it on, and there wasn't that big of a backlash. We are actually experiencing negative consequences from too much protection of our psychiatric records, for example, where we have sort of walled it off from primary care physicians, for example. And so it's sort of a spotty problem, but every once in a while, the primary care physician will say, this is ridiculous. How can I treat this patient if I can't figure out what happened in that group visit or something like that? So I would say the fears, some of those fears are sound, but not nearly as many. And that as a society, I would push that envelope, see where we get, and then back off. All right, so then, how do healthcare organizations respond? And then for you to be thinking about as I talk, how should healthcare organizations respond? I'll talk about a couple of areas. We do a lot of proactive population care. I'll go a little bit more into some of our shared decision-making tools. Building clinical pathways and doing operational improvement leads us to more reliable care and also less variation in care, so that we really want to preserve physician judgment, but it's also really important that the kind of treatment you get doesn't depend on who you see, that it would be you would get the same quality of treatment no matter which facility you walked into. So that's that third bullet. And then I think for this audience, you're probably interested in some of the guidelines that we've put in our organization around interactions with social media. So population care. We embrace a concept we call complete care, giving my patients everything they need, whether they know they need it or not. It makes me feel good about my practice. And we involve both, and that involves both needing data and information, and then the people and process and technology systems that we put in to support intelligent use and effective use of that data, and a real focus on the patient. Complete care is for the patient. It's not for us to make our lives easier, make things more efficient. It's about the patient. So we have, within Kaiser, and this capability is increasingly possible in other healthcare organizations with an electronic medical record, a database of common chronic conditions and some of the preventive care that people should be getting, both if you're healthy and also if you happen to have one of the common chronic conditions. So the entire database is continuously scanned for conditions such as asthma, diabetes, and coronary artery disease. And what you see here on the right-hand side is one of the views that we have of what we call care gaps. And across the top are care gaps by chronic condition. And then also, I'm not sure we can see it on this particular screen, but we also do prevention care gaps. Of note, this capability was not built into a lot of the electronic medical records that are being sold in America, because a lot of them are really focused on that documenting the one-on-one visit. And so most healthcare organizations have had to go out there and build custom software to do population care. So I'm showing you our custom software version of this. So then our clinical care teams have a member-centric view of all the care gaps. And then all of our members are empaneled, assigned essentially to a primary care physician. And that primary care physician has a team. And the physician and the team addresses all the care gaps. They get sort of a little score of how well their patient population is doing. And then they receive support and training and resources for proactive care. And what that might mean is that for half an hour a day, instead of seeing a patient in an office, you do what we call desktop medicine, which is address the care gaps of the patients who have not shown up at your office. And then we reach out to members even if they have not come back to us. So that's what we do for many of our primary care conditions. We also have some targeted populations. So some registries. Registries are essentially beefed up lists of children. We do some work around chronic kidney disease and hepatitis. And this is a frontier for us. We're trying to figure out what the new conditions should be that are really amenable to this sort of data analysis. And there are some conditions that aren't. Kidney disease is one that it's really easy to sort of pick out progression of disease from discrete pieces of lab data. So that was a real opportunity area for us. Heart disease is much harder to pick up from discrete values in the electronic medical record. So we're trying to figure out these new conditions. And then we also have registries for select procedures like joints and ligaments and shoulder replacements and hip fractures. And what we're able to do from these registries is sort of understand which joints are doing the best in our patients, and then really mobilize around, if there's a particular joint that's been recalled or having problems, for us to reach out and say, hey, you had your hip replacement 3 years ago, and we just heard from the manufacturer that blah, blah, blah. So let us, bring you in for some additional monitoring or that sort of thing. And we are moving into registries, so in terms of other conditions being piloted, really thinking about survivorship, particularly survivorship of cancer, and conditions like that. And, there are some conditions that that previously were fatal, and now the majority of patients are recovering from them, and they're living 20, 30 years, and they're getting another disease on top of that very serious condition. So how do we make sure, that 20 years after your cancer survival, that when you come back to see the physician, we remember what medications you were on and what kinds of additional side effects we should be watching out for. So then we have, all this data about populations, and then up here in the upper right-hand corner, we do a lot of education of to our patients about the importance of examining these care gaps. So this is a poster from our Northern California medical office saying this is the most important thing we examine today, and it's that list that we print out at the beginning of the visit. It actually comes on your receipt with your copayment that says, you were due for a mammography and you didn't come in, or you did come in and the last day you were screened was this. We use a lot of members in our various advisory councils, and one of our members, Nance, she said the other day in one of our advisory meetings, she said, this is one of the ways that Kaiser Permanente can give me a cheap thrill, because I look at this list and I go, woohoo, I did 8 out of 9 things that I'm supposed to do. Good job, Nance. So we're constantly enhancing this capability, but it's really important for us to engage our patients as partners in filling the care gaps. And then we have systems that support it. Our two biggest systems that support this sort of work, this one is called the Proactive Office Encounter. So the Proactive Office Encounter means that we really gear up. If you decide to come in for a visit, regardless of whether it's because you had an asthma attack or whatever, we really gear up to try and maximize that visit. So before the visit, we have our medical assistants and our nurse identify missing labs, screenings. We figure out what your status is on whether you've logged into our online portal. We provide member instructions if necessary, and if necessary, we contact the member and say, hey, before you come in, make sure you go to the lab and get your blood drawn, or before you come in, you might want to read this particular piece of literature that we've put up for you on kp.org. Then during the visit, the team, the non-physician team, does vital sign collection, identifies and flags alerts for the provider, prepares the patients, and does follow-up on the things that they talked about in that telephone call before the encounter. And then afterwards, we make sure all our patients leave with an after-visit summary with some care instructions. If appropriate, and this turns out to be really important, we actually make sure that their follow-up appointment is already booked, because it just increases the likelihood that they will actually have a follow-up appointment. And so that's our proactive office encounter, and it really requires a lot of training, a lot of support, but it's also really incredibly rewarding, where we'll say, we'll hear from the receptionist, this, I thought when I got this job, I was just signing people in, but now I really feel like I'm part of the care team and I'm part of helping someone save a life. And on YouTube, we actually have a video of one of our members who, the receptionist was especially persistent about getting her booked for a mammography the day that she came to the appointment, and the receptionist, while she was in the visit, made sure that the appointment was booked. It was for that same day, and they did catch a lump in that mammography. And so, the video is one of the members describing how she feels like the receptionist helped save her life. And then we're doing several versions of this kind of work with offloading work to the care team and devising roles for the pharmacist, for the social worker, for the care manager in our medical homes. And then this is just an example of, then how do we make the right thing easier to do from a member perspective? We have reminder calls, we do kp.org, we have facility posters, we do reminder letters. And then actually at the Care Management Institute, we do a fair amount of work on understanding member needs, particularly when they're not clinical. So these bullet points are from a study that we did on patient experiences when they go from the hospital to their homes. When we first started the study, a lot of the questions were clinical, or rather, a lot of the assumptions we had around why patients were readmitted to the hospital were because of clinical. And if you review their medical records, indeed, there was some clinical condition that brought them back to the hospital. But if you went down and did a root cause analysis, you really understand that, for example, leaving the hospital without a follow-up visit really meant that they didn't come to the follow-up visit because, it was too hard to make one, and that then caused the clinical condition. And then we are doing a fair amount of work in figuring out what the specialist's role is in population care. So this particular study published in British Medical Journal is of one of our nephrologists in Hawaii. So usually specialists feel like the people they need to take care of are the people who walk into their office. But this particular nephrologist was sitting, he was an engineer before he was a doctor. He had downloaded the records of all the patients in Hawaii and built a little predictive algorithm to figure out whether or not they would show up in the emergency department. And kind of watched over the course of 6 months, and golly gee, those patients actually did show up in the emergency department. At which point his sense of responsibility kicked in, and he said, you know what, these patients were not referred to me, they really needed to be referred to me, and my responsibility is not just to the patients who come into my office, but to the entire population of Hawaii. So we are really pushing that. It's a message that primary care is very comfortable with, but it's not something that specialties are particularly comfortable with. So I wanted to flag that to you as one of the areas. Showing you some of our tools around shared decision making. I think I said enough earlier about the importance, and so we're just trying to put in some tools, but I think there's a weakness there in terms of how we could share decision making with patients, and I think that at the moment we're still, as a healthcare delivery system, in the driving seat, and I think that there's a lot of room for the patient to become more in the driving seat for that. And then we do work around defining clinical pathways, taking the evidence, putting together a workflow around that evidence, and then putting in decision support like order sets, reminders, to make it easy to do, and then doing the analytics and evaluation around it. I'm showing you our particular pathway around sepsis that will lead to early goal-directed therapy, and we had discovered that sepsis was the leading cause of mortality in our hospitals. And through this pathway work, we're able to redesign our workflow around sepsis and really reduce deaths from sepsis. So it's some of the very exciting work that we've done. And then I put this slide up to sort of describe what it means to be on a pathway. That a lot of our current interventions are sort of about a point in time. I got a diagnosis, I'm going to do something about it. But especially for chronic conditions and serious illnesses, it's a journey. It's a journey for a year. It's a journey for many years. And so you need to lay out what that journey, what the different paths and the different milestones are on that journey, and what the roles are of the different people on the care team. And this particular pathway, I'm showing it as a cause and effect diagram, but it eventually turned into a pathway as around breast cancer survivorship. You survive breast cancer, and 3 years on, what's the role of a healthcare delivery system in surveillance, in clinical surveillance, for recurrence, for side effects, in psychosocial surveillance, and does that happen in the oncologist's office or in the primary care office or the radiologist's office? And also, what is the role of the patient, and what is the role of our technology systems in supporting that pathway? I'm rushing a little bit because I'm noticing the time, but I wanted to show you our guidelines for engaging with social media. We are not infants in this, but I would say that we're feeling our way. And pretty successfully, we've really enjoyed our experimentation with social media. And so those are our principles: listen to and respond to our members, nurture employees and physicians as responsible, thoughtful spokespeople, extend the reach of media stories through conversations, and participate as people and build relationships. So we do have blogs, we have a Facebook site, we have a YouTube channel. And the questions that we really had to ask ourselves when we first started down this road was, are we ready to talk about the good and the bad? Because if we're not ready to talk about the bad, we shouldn't be out there. Are we willing to engage in direct one-on-one conversations with consumers? Are we ready for everyone to view those conversations? And are we willing to show the consumer that our organization can change based on those interactions? And if we're not able to answer yes, then we shouldn't be out there. So that's philosophically where we started. And then I'll just show you an example of how we listen to and respond to our members. So these are comments posted on our Facebook page based on a particular video. And so there was a member who complained about the idea that she couldn't get her medical record from us. And then we reached out and actually helped with, essentially service recovery, where we said, this is how you might be able to get your record. And she came back and posted on the page. And then participate as people. Teddy Ten's one of our physicians who's one of our best ambassadors, and he's really developed a relationship with Regina Holiday, whose husband died of cancer, and she has really become a patient advocate. So we really feel like we need to be very genuine. So I'm bringing us back to that first question, what do you want to do with your health? And reflecting on what I said, how should we respond? And I would submit that what I've described is that we've responded in that area that I've circled. And that there's a lot of room for a healthcare delivery system to address the other parts that I have not circled. And then I'll tell you a little bit about the challenges, and then I'll stop for questions. What are the opportunities? I won't call them challenges. And one of the biggest ones is around big data. Big data refers to data sets whose size is beyond the ability of data software tools to capture. It's characterized by volume, variety, and velocity. And the biggest examples of these are some of these sensors. And patients want to send data about those sensors, from those sensors to our physicians. And, in some ways, our physicians sort of want to see the data. But imagine the flood, imagine the volume. What are we supposed to do in response? How do we make treatment decisions when we're overwhelmed by data? And so there's a lot of work in terms of turning data into knowledge. Kaiser Permanente has a genome project. The acronym is huge. It's, I think, I can't tell you exactly what the acronym is for, but it's understanding the effects of genes and the environment on health. And we're doing work on biometric monitoring, collaborative authoring of the care plan. We actually have a lot of work to do in old data, so doing data mining for clinical effectiveness and graphing our data to get better insight. And also we have a lot of opportunity in linking old data to new data. And I'll just tell you the graphics I'm showing. We've got a total health initiative that tries to map park access to obesity to try and understand how park access affects the obesity of our members. And then this bottom graph we can't take credit for, but it's the way that Patients Like Me has graphed the progression of Lou Gehrig's disease over time to help understand whether or not this particular graph is about how well patients did on lithium, and the lack of a pattern demonstrates that lithium is not actually that effective for Lou Gehrig's disease. And I'll stop at this slide because these are our big headaches in terms of policy issues around big data, the privacy. Whether or not data can actually be identified in an era of genomics, we're pretty sure it can't. What privileges do people have over pieces of data? Security, intellectual property, and actually, liability. Although I wouldn't say that liability is the one that's the biggest. I think that the first three are the ones that we're struggling with the most at this moment. So I'll stop here and take some questions.
Thank you. So how is the social media helping you to devise new products? For example, back pain, lower back, upper back. I used to work for care management in United Health. So I'm very curious about that. And the second question is that besides volume, velocity, and all that, there's a veracity, right? Truthfulness, right? A lot of junk coming up in big data. So how do you handle all that? Thank you.
I'll tackle the second one first. We're not actually that worried about veracity, and part of the reason is because of the volume and variety. And basically, the hypothesis is that with enough volume and variety, you will get enough cross-correlation that veracity of a particular piece of data is less important. With social media, I would say that in our general forums like Facebook, we're just spotting for big trends. And then we do have Facebook pages, for example, for some of our groups that are on a particular kind of diet program. And those then we do, right now I would say we don't use very good tools for it, so we are doing mostly by hand. And we have enthusiasm around the possibility of doing natural language processing or something to discover more patterns. But right now it's by hand, and it's really a qualitative feedback, but it's, before we used to use focus groups, so now we don't even need the focus groups. So I think we're like the industry in that way. We're using it that way.
I think we can take one more question if we have it.
If you could team up with an organization like ours, in other words, with an academic research community, what would be the most important things that you would want us to do to amplify your efforts?
Steve and I were just talking about this beforehand, and I think it starts with the gap that we've been noticing in terms of treatment and managing illness. That we think that there's very robust work going on in wellness and in relatively well populations, and we're in that population essentially going to buy stuff off the shelf. And there's really interesting work going on in diagnosis, where we're applying really cutting-edge algorithms to figure out stuff, and that, we're very appreciative of the work that you do in diagnosis. But in treatment, once we've got that diagnosis, what do we do? And how, especially for healthcare organizations across America facing a big push in efficiency and effectiveness, right now we tend to throw people at problems, and even with some of the technology we put out there, we're like, here's your technology and your dedicated care manager, right? That we really need to figure out how to do treatment in a way that's efficient for a healthcare organization, because otherwise we'll kill ourselves.
One follow.
So is it decision support that's the challenge, or is it figuring out what the treatment should be?
It's most concrete in the area of behavioral health. So Medicare now requires a total health assessment. We deploy it, at the first visit, and we ask, one of the questions we ask is essentially, do you feel lonely? And lots of people say they feel lonely. We don't know what to do about that. We have depression treatment programs if you're actually depressed, and then this whole space of, do we recommend a game to you? Do we, if we recommend a game, what's our role in the game? And even what's the feedback? Let's say we have no role in the game, but they want to come back and tell us about the game. How many of these games do we educate our providers on so that we can have a meaningful conversation? So it is treatment. I wouldn't necessarily say about what kind of treatment, but about how to deliver the kind of treatment that we know is effective.
Dr. Cain, thank you very, very much. Thank you all for being here today.
Thank you.